Before we get started, I have a quick favor. I've been self-funding the Finding Genius podcast for 5 years now. I've done over 3,000 episodes. And as you can see on YouTube, we're up over 1 million views on the channel, which is fantastic. The next thing I really want to push on is to get up to 10,000 subscribers. Because once we do, we'll be able to put a donate button and we'll be able to solicit donations to help keep the podcast running and to also get the Finding Genius Foundation moving along. We have a big project studying anxiety, depression, and PTSD and working on a product to help people overcome these problems because I've seen them explode recently after the last 2 years of the whole virus situation. So if you would, please subscribe to the podcast. That would help us tremendously. Give us a thumbs up and check in the description for Buy Me a Coffee. It's about $5. If you could buy me a coffee, I'd really appreciate it. It would help keep the channel going, and I love coffee. Thank you.
Forget frequently asked questions,
common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast, now part of the Finding Genius Foundation. I have Dr. Lisa von Moltke. She's the Executive Vice President and Chief Medical Officer at Seres Therapeutics. And the website is SeresTherapeutics.com. So Lisa, thanks for coming.
Pleasure to be with you today.
Yeah, if you would, tell me a bit about your background and how you came to Seres, and then after that, I'll ask you about Seres itself.
Sure. So I am a physician by training, and I focused on internal medicine and a fellowship in clinical pharmacology, which is very interested in drug metabolism and transport, and I'll come back to that in a bit. I was an academic for quite some time in a university lab before joining industry, and particularly the biotech sector, in the mid-2000s. And since that time, I've worked at a number of small places and very large places, and in a number of therapeutic areas. But I got the opportunity to investigate Seres just before the pandemic started. So late, what was it, 2019, early 2020. And as I mentioned, I've always, I've had an interest in drug metabolism. We've known for a long time that there were intestinal microbes down there doing all sorts of things, metabolizing things, generating metabolites. Over the course of my pharmaceutical career, it was becoming really clear that the complexity and sophistication of the human microbiome was something that was not only much more important than we ever understood, but really an incredible determinant of health, disease, and response to therapies. And I think one of the things that I was experiencing in my last job was just the information coming out of the oncology world on response to one of the new and most successful classes of drugs, the checkpoint inhibitors, being so tied to whether or not someone's microbiome had seen antibiotics. So in fact, the fact that your microbiome could be damaged or impaired in a way such that affected your ability to respond to cancer chemotherapy was just an amazing piece of evidence that was resonating across medicine. So at the time when I had the chance to evaluate Seres on the backdrop of all this really intriguing work coming out of all sorts of fields, not the least of which is oncology, I was really amazed to see what Seres was bringing to bear in their approach to the microbiome. And by that, I mean, I had been aware that there had been some non-specific attempts at innovation, most commonly referred to as fecal transplant. But Seres had been at it for 10 years and had actually been applying state-of-the-art kinds of approaches to identifying microorganisms and being able to classify them, genetically classify them, and even more importantly, to be able to determine their function. what these microbes were doing down there in terms of producing metabolites that are potentially important to the host, which are people, and also communicating with other microbes that are in the microbiome. And so I thought if any company could potentially help move the field forward and unlock the potential, it is a company that is applying the same kind of scientific rigor that's being applied in other areas, the same sophisticated tools. And I said, sign me up.
And what does your work in Seres comprise of now? Like, what are the focuses of Seres Therapeutics?
Yeah. Well, I'm the chief medical officer, which means that I'm on the clinical development side. And I take all that, the work that's gone into producing a therapy, and we put it into clinical trials. And in the same way there's been rigor in the science, we've been employing that same kind of rigor in the clinic by doing state-of-the-art kinds of clinical trials. So in other words, blinded, placebo-controlled, so we can get a really accurate look at whether the therapies are doing what we want. And we've got a number of therapeutic areas we're interested in. The one that's furthest along is our therapy, the investigational therapy for C. difficile infection. And I can come back to that in a second and tell you more about that. We also have therapies that are underway in trials for ulcerative colitis, so a kind of inflammatory bowel disease. Have a therapy that's getting started in graft versus host disease and trying to prevent infection in people undergoing bone marrow transplant. And the company is also very interested in doing work in metabolic areas. So really across a wide range of therapeutic areas, which reflects really the feeling in the medical field about all the potential places the microbiome may have a really significant role.
Can we start with the C. difficile? What is the condition? How does it arise? What does it do to people, and what's your therapy targeting?
Yeah, so C. difficile infection is a kind of diarrhea, infectious diarrhea, that is unique in its ability and likelihood of recurring. And these poor patients, once they get an episode, they're incredibly likely to get another episode and another episode and on and on. It is caused by an initial insult to the patient's microbiome, the most common one being some kind of broad spectrum antibiotic that a patient needs for something, whether it's a dental problem or cellulitis or a pneumonia, something where they need to be treated. But that antibiotic, in addition to killing the bugs that are causing problem, we now know that those antibiotics can cause damage to those healthy bacteria, those good bacteria, if you will, those microbiome players in the GI tract that are important for doing all sorts of things that keep us healthy. And one of the things they do is they outcompete bad bacteria, if you will, by using up the food and the space and all of that. They produce certain kinds of chemicals that make it very difficult for bad bacteria to grow. And so when we lose those good bacteria, suddenly there's space for bad bacteria, and C. diff is one of them. There's not this chemical protection that the good bacteria normally produce. So as a result of that, the patients then will be treated for the C. diff infection, but there's a bit of a residual nidus, if you will. It's actually a spore. It's not the vegetative bacteria, but I realize this is a fine distinction, but it's a very resilient piece of the puzzle for C. diff that remains, that if that healthy microbiome were there, would be able to keep that spore from generating and causing the C. diff infection again. But because it's not there, the C. diff explodes, the patients develop incredibly profuse diarrhea. Many of them are hospitalized, and they go through this cycle of antibiotic treatment and recurrence, for some of them a number of times. So what SER-109, our investigational therapy for C. diff, does is it comes along in after the patients had antibiotics the first time for the C. diff or C. diff infection, and quickly delivers back the good bacteria that patients need to have in their intestine.
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs, and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now back to the show.
And it's a particular kind of bacteria. They're called the firmicutes. And those bacteria then bloom and go back to occupying their rightful place in the GI tract. And they not only occupy that space, they produce the kind of chemical environment that is normal and healthy and keeps C. diff from being able to germinate again.
Don't people have some low level of C. diff in them at all times? And I guess it just increases dramatically when it takes over?
That is a very good question or a very good point. There are a fair number of people who are either carriers, they're asymptomatic carriers, or we sometimes call them colonized if they're carrying a large amount. But the reason that they're carrying the spores, and the reason that that's not a problem is because the rest of their microbiome is doing all the things we just discussed. It is competing for nutrients and space. It is producing these secondary bile acids, which C. diff doesn't like. And as a result, those spores stay just that, spores, and don't cause problems. It's when that environment is changed. And again, the most common cause of that is a broad spectrum antibiotic. When that microbiome environment is changed, that suddenly, the spores now have a window of opportunity during that time where they can now germinate. And that is exactly what happens. C. diff is a common organism in the environment, and it's a resilient, healthy microbiome that is responsible for the fact that we're not all running around having C. diff and diarrhea all the time.
So the firmicutes, they produce metabolites we need, but they also produce, metabolites that dampen the activity of C. diff. Is that what happens? Like, what's their interaction with C. diff?
Yeah, the main mechanistic sort of underpinnings, if you will, are just what I described, which is the conversion of primary to secondary bile acids, which actually inhibit the growth and the germination of the C. diff spores. So that is a key thing, a key function of the firmicutes in terms of what they do. We also know that they do compete for carbon sources and just other resources that make it difficult for any little vegetative thing that might slip through, just finding a very inhospitable environment.
Okay. So the protocol is to give probiotics, or, how do you help restore this balance and knock out the C. diff? Is it, again, antibiotics coupled with probiotics? Like, what's the protocol?
Yeah, it's the antibiotics, because once the patients are in the throes of diarrhea, that's because the spores have already germinated, horses out of the barn, if you will. They're now not spores, they're vegetative, growing, and they're producing toxin, and the toxins is what makes people sick. So we come back in with a standard of care, antibiotics, knock those vegetative bacteria back down. Now, antibiotics don't do anything to spores. So we're back down to the spore state, and the spores are sitting there. We enter in with SER 109, which is a consortia of these firmicute spores themselves. We administer, and those are orally for 3 days, and they engraft, those spores engraft and bloom and vegetate and produce the intestinal flora, the intestinal bacteria that is more commonly in healthy people, and produce those environmental pressures that we just discussed.
If you like this podcast, Please click the link in the description to subscribe and review us on iTunes.
So I
Okay.
would say that it's not really a probiotic in the sense that most people mean probiotic. It's maybe a subtle difference, but it's a microbiome therapy.
Yeah, it makes sense. So what other, when you do this, and so you're left with, when you take the antibiotics, it kills a whole bunch of C. diff, but it leaves the spores. Are there any side effects from that, from the mass die-off of C. diff? Do they release toxins? And then when you have these spores are all that's left, and then you add in the Firmicutes spores, again, is there another die-off of the other spores? Like, what happens to them? How do they passage out of the body, and does that cause any other problems for people?
Yeah, those are great questions. The dying off doesn't seem to be any more problematic than just the toxin production. I mean, their C. diff is going great guns producing toxin when left to its own devices. So coming in with the antibiotics to knock that down and kill the vegetative bacteria, actually people respond and get symptomatic relief pretty quickly, which is really reassuring to see. And so antibiotics really do work to control that initial diarrhea. And then with regard to the second question, well, what we saw in our study is that patients really don't have any problem in terms of anything that happens with administration of the new spores, if you will. What we do know is that after patients have had C. diff, they will shed C. diff spores for some time. And in fact, that's one of the reasons that there is a recommendation you don't go checking to see if somebody is now C. diff negative in terms of just a PCR test or something like that after you've treated, because you'll pick up that they're still excreting spores, even though they're no longer having active diarrhea and symptomatic, but they feel much better. So they feel back to normal, even though they may be still shedding some spores. So it really is it's the completion of the therapeutic cycle, if you will, piece that has been missing for so long with this particular illness. And it really was an amazing result that came out of the trial last summer, certainly a more pronounced result than we or really folks in the field had even expected, and very gratifying for the patients, since it looks like there's something that can help them get back to health.
Yeah, that's excellent. I know we can't talk about everything that Seres is doing, but can you talk about one more product that you're very excited about? And we'll ask a few questions around that.
Sure. Well, I think the next thing that's up in the pipeline is our therapy that's in a phase 2b study for ulcerative colitis. And that's an inflammatory bowel disease and affects an awful lot of folks around the world, and is actually a growing problem for reasons that are not quite clear, but maybe tied potentially to the spread of the Western diet, among other things. And this investigational therapy is particularly now in studies for patients with mild to moderate ulcerative colitis. And that's the biggest group of patients with ulcerative colitis. And they're a group of patients who very often are undertreated. And that's because the current treatments that are available, for the most part, are global immunosuppressants. So patients have to make a decision about whether to take some of their medication options to feel better and weigh that against opportunistic infections, increased risks of neoplasia and fomas, and in some of the other therapies, they've got their own cardiovascular toxicities. So it's really significant toxicities. So for these patients who are more mildly affected, they still may be having 5 bowel movements a day. They may be bleeding when they go to the bathroom. They may have continued urgency that feels like they have to run to the bathroom, or it wakes them up in the middle of the night. But they may think, well, maybe I can tolerate just half the number of trips to the bathroom, or maybe only getting up once in the night, rather than take something that I'm afraid is going to result in my getting lymphoma or skin cancer or something like that. So the field, this group of patients is really in need of something that could give them some benefit without that kind of baggage. And one thing about the microbiome therapies that we've seen at Seres is because they're commensal bacteria that have evolved with us over centuries, they really don't have a toxicity profile that's of any significance. One of the things that we saw even in the C. diff program is that the adverse event profile looked identical to placebo. And in fact, in the ulcerative colitis programs, in our earliest program, the AE profile looked better in the treatment group. And the things that occur tend to be gas or a little GI cramping, something like that. So it's really presented the opportunity to potentially intervene in this disease, in ulcerative colitis, for this mild to moderate group, which is definitely undertreated and is not willing very often to take the next therapeutic step unless they can have something that they feel has a better risk-benefit profile. And I'll also say that the microbiome approach here offers another unique feature in addition to the safety profile. For a disease like ulcerative colitis, the sense is that it's a heterogeneous and probably multifactorial disease, an interplay of a number of factors resulting in a lot of excess inflammation directed at the host, and then the sequelae that we see with the damage to the intestinal lining and the symptoms that we just talked about, but also increased risk for colon cancer as a result of the ongoing inflammation. So we know that there are likely multiple pathways that could be implicated, and potentially different pathways in different people. So by using a microbiome approach, and again, looking at the function of the bacteria that we're choosing, the abilities of these bacterial species to form metabolites and substances that are anti-inflammatory, that promote mucin production and barrier integrity in cells, that do other things that are immunomodulatory at a local level. We can deliver a therapy that has the potential to hit a number of pathways simultaneously in a way that you can't do with a directed therapy, right? If you're going after one cytokine or cytokine-oid factor, that's a very precise directed therapy, but for a multifactorial disease, that may leave some gaps. And because the therapies that are available have these significant toxicities, it's been pretty difficult to combine therapies. There is a little bit of that's done with in the early lines of therapy, but it becomes problematic pretty quickly, just again, because of these compounded toxicities. So in addition to microbiome therapies potentially allowing us to go after multiple targets at once, if they stay looking as safe as they have been, you could imagine that they could also be used in combination with some of the other bigger guns that you wouldn't want to add significant toxicities to. So we're really excited about that.
It sounds like, I guess C. difficile is understood a lot better so far than ulcerative colitis. You said it's likely multifactorial, but is there any insight into, specifically the microbiome angle, what's happening in people with this ulcerative colitis? Like, are there certain microbial players that are increased or decreased? Any knowledge there?
Yeah, so those are absolutely fantastic questions, and you are spot on that the C. diff, while it was not an easy nut to crack, it was a much more straightforward microbiome play, if you will. With regard to the pathogenesis and the bacterial players and the pathogenesis of ulcerative colitis, it's not really thought to be something that's pathogen driven kind of thing. So we can't really go after a specific player like you go after in C. diff that we know is the bad actor. What we're aiming to do is to go in and produce things like short chain fatty acids, tryptophan metabolites, things that we know are important in indole production, and things that we've been able to look at in the lab and in models, and then get some kind of human confirmatory evidence that suggests that by augmenting the function of those kinds of capabilities, that we can actually do things like help with the healing of the mucosal surface, reduce the inflammation and some of the inflammatory signals that are happening at a local level. So it's really, again, more around the function. And that's also interesting because we and others have seen that different people might have different bugs doing that function. So you may have a bug A, who can perform these really important functions. Somebody else might have bug M that can perform those very important functions. So it's not so much that we think people need to have the identical microbiomes with identical bugs. They need to have these functions. And some of our therapies, including our therapy for ulcerative colitis, have redundancies built in so that we may be supplying more than one bug that can produce these needed functions, with the best shot of having the right bug that is fitting in your ecosystem take root and produce those functions. So it's a complicated social environment within these microbiome spheres, and there's not going to be one definition of healthy in terms of who's there, but in terms of what they're doing, there does seem to be some common thread.
Yeah, it seems like our microbiomes are like a job center. So as you said, if microbe A could do the job, sometimes microbe B for me or microbe C for someone else. So I guess it makes sense that there's that redundancy. It helps keep us going and ensure that there's not just one type of bacteria that can help us.
Yep, that's a really great analogy. Yep.
Do you have any sense of, I call it like bacterial economics? So if I'm a bacteria and I produce a certain metabolite, how many of those metabolite molecules do I produce in exchange for how many, let's say, sugar molecules that, the body gives me, or short chain fatty acid molecules or whatever, some other metabolite? Does anyone have a sense of, what the parameters are on the trading of these metabolites?
Yeah, so that's an excellent question. I am not the person to answer that, but one of the things that attracted me to Seres is that we have a bunch of people working in our discovery group who actually are the right people to answer that. And those are exactly the kinds of questions that they've been asking and the kind of work that they've been doing for 10 years, which is why they've got an understanding of, as I said, not only who's down there, but what they're doing and what kind of conditions they need in order to do their work. And that's what the depth that I think is really special about the organization.
Okay, well, very good. Best way for people to keep tabs, go to serestherapeutics.com, or what's your recommendation? How can they find out more?
Yeah, I think that's a great way to start. And I'm pretty sure we have social media presence as well for those who are more facile with social media than I am. But definitely our website keeps people informed.
Okay, very good. And then last question, what's in the pipeline for the next year versus the next 5 years? If you can say it, if you can, it's okay. But what can people expect to see clinically? What clinical solutions are coming and when do you see?
Yeah, I've given you a little bit of a glimpse in terms of inflammatory bowel disease and our work in graft versus host. We remain also incredibly interested in oncology and all aspects, including immuno-oncology, in anything related to immunomodulation, as you can imagine from just the topics we've discovered are right in our sweet spot. But I would say the other thing I spend a lot of time thinking about and is a really critical problem for all of us, the healthcare system, is resistant bacteria and our ability, the ability of the microbiome to help control infections that are increasingly produced by resistant organisms, so as known as the escape pathogens. And so I think you can look to Seres to continue to be interested in working in that area as well.
Well, very good. Well, Lisa, thank you for coming on the podcast and talking about Seres. I appreciate it.
Oh, my pleasure. Thank you so much for having me.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.